All right, good morning, everyone, and thank you for joining us today for another edition of Senior Tech Coffee. And today we're going to be talking about communication technology in older adult care. This will be the third part in the series. And today I have three very special guests, the folks involved with the technology implementation at the new Open Arms Assisted Living facility, which is in East Denver in Montbello. And I want to welcome my guests, Morgan Jenkins, Suzan Perreault, and Peter Hynes. Welcome, everyone. And also a big welcome to all of the guests who have joined us for this conversation today. So thank you very much. Senior Tech Coffee, of course, is brought to you by Prime of Life Tech, providing IT tech support and training for our older adult community, small businesses, and senior care professionals. And I want to spend a few minutes introducing our guests and allowing them to tell us a bit about themselves and how they got involved in the technology initiative at Open Arms, but also just generally how they were involved in getting Open Arms Assisted Living up and running and launched, and which was a huge accomplishment, I know, and a lot of hard work went into that. Let's start, and I'm going to ask a few questions of each of you, and I'm going to start first with Morgan Jenkins. I know Morgan through networking circles, and I know that Open Arms is a big, it was a passion project for her. She's a volunteer and a board member. And Morgan, could you just give us a little bit of your background and how long have you worked in senior care?
Sure, thank you, Patrick. I'm happy to be here today and talk about this project. It's certainly a passion. My background is actually in psychology. I have a master's level degree, and I started in the home health world when I took my first job with Amazing Care Home Health back in 2010. So I worked in the acute care setting for about 3 years after that. And about 4 years ago, I started with Maintain Me. And Maintain Me is a consulting and placement agency and case management agency, and locally owned and operated. But what I saw in that role is there was a great need for affordable assisted living for people who were on Medicaid that still needed a quality place to call home. And I have been on the Jefferson County Aging Well Council 3 years now, and joined the housing work group, which is where Donna Mullins introduced me to Peter Hynes and said, "You are interested in affordable assisted living? Well, here is Peter, he's building one." And I said, "Cool, how do I get involved?" So I sat down with Peter on a couple different occasions, and he gave me an invitation to join the board of directors. It's my first position as a board of directors, and that was just over 2 years ago, I think we're coming up on. Yeah. So yeah, that's kind of how I got involved.
That's great, thank you. And let's go next with Suzan, please. Suzan, again, same questions. A little bit about your background. How long have you worked in elder care or supporting industry, and how did you get involved with Open Arms?
Thank you very much, Patrick. Appreciate us being here. Wow. So I've got about almost 30 years of IT background. I spent most of my career at Intel Corporation in Silicon Valley. And we moved here as a family probably about 13, 14 years ago. And when I came, we were still doing project management, still doing IT. And then about 5 years ago, my husband challenged me for us to do something different and to start tapping into technology when it came to seniors. So we actually, it's kind of funny, we actually started telehealth about 5, 6 years ago, and we would do down in Colorado Springs these forums on a very small, intimate, trying to get providers and clinicians and the medical community interested in telehealth and telemedicine. just on a smaller scale. And then through that, I actually came to Denver to watch one of our speakers talk about what he had spoken to us, just kind of supporting him. And I ran into Peter. We had a question around billing and remote patient monitoring, and he had some pretty interesting questions that I thought was pretty great. So we started this conversation afterwards, and then it just kind of grew from there. So we actually had an interest of a technology that was around remote patient monitoring, but it was really hard about 5 years ago where people were not as interested in telehealth and telemedicine. But Peter had these really forward-thinking ideas. I mean, Morgan, you're on the mark about, where he wanted to take open arms, the technology he wanted to use, the service he wanted to provide. So we had these conversations afterwards, and I got involved probably about 18 months ago, got on the board, and now we facilitate the telehealth and telemedicine care for the residents at Open Arms.
Excellent, excellent. And Peter, please take it away.
Well, thanks, Patrick. I appreciate it. And nothing would happen without Morgan and Suzan, that's for sure. We've got a great board of directors and a great team, and everybody's really been hands-on, and no one could ask for more. But the story behind Open Arms, which is what I can offer here, is really kind of interesting. The property is historically St. Andrew Lutheran Church. And it was about five and a half years ago now, where the St. Andrew Lutheran Church came to me and said, hey, we have a vacant elementary school, but our church is still functioning. There's 4 congregations that are using the sanctuary. So what do we do about, 13,000 square feet of empty space? Well, churches are not in the business of trying to figure out what to do with buildings. So they asked me to come and think about it. And I said, sure. And just thinking through it and evaluating all the aspects of construction and how to finance the thing, what we came up with was the vision of converting that school, keeping the church going full steam ahead, creating a nonprofit to convert this school to affordable assisted living, knowing that Montbello was going to be a market that probably would not be in the straight up market rate of assisted living care. They have a high Medicaid population, high veteran population. The income level is not as high as other places. So we figured maybe we can back into the costs of the project by juggling the technology that we could use to put in there and create revenues, the actual construction costs of using an existing building and land, and then can we balance that out with what we would have to actually pay to operate the project? So juggling all the factors of those equations, we worked through the state, we worked through the city, we worked through what we knew about Medicare and Medicaid in order to create a telehealth program that would be able to be revenue generating and then not over encumbering the actual operational costs of the facility. So we really kind of had to juggle a lot of new things, and it was some bumps in the road, and then there were some clean days of sailing. At the end of the day, it did take us about 5 years to get everything approved and understood and in process, and then the actual project built. We've now been open since, technically we've been open since August, end of August. We were licensed in early November. So we've been functional and operating now for almost 3 months. And after, 5.5 years and lots of fantastic help and lots of input in it from our advisors, from social services, from the medical profession, from the transition agents, from technology, from construction, all the way down to, pastoral support from the church. It's been just a wonderful ride.
Nice. So have all 3 of you been involved over the course of the last 5.5 years, or did you come along? Please jump in and give me your contribution to the story. When did you join the origin story of Open Arms?
So the origin came from St. Andrew Lutheran, and we created an advisory committee before we had even a nonprofit structure in place. So we created the advisory committee, We brought in people from a network I have that come from caregiving, that come from social services, that come from nursing, that come from finance. And we brought them all together in this committee basis to see if we can pull this off. And then as that evolved, we turned it into a nonprofit organization. And some of those early advisors stepped off, and then new board members stepped on. And it's really the board we have now has been around for probably 2.5 years, maybe going on 3 for the most part. The board is in bylaw. The board is always governed by, the president will be a member of the St. Andrew Lutheran Church. So the church always has, their stake in the game, and they're there from a governance perspective and from an occupancy perspective. And they participate on a daily basis. So from there, Morgan and Suzan, you guys can jump in and kind of describe how you gotten on the boat.
Morgan, you've been on longer than I have. Go for it.
Yeah, not too much longer, but it was October 2019, I believe, is when I, at least, I think that's when I attended my first board meeting, and then was voted in the next month after. So it's been since then. And Suzan, I think you came just right after me. It was very close.
Yeah, I think it was too. So when I met Peter at the conference that John was talking to, he invited me. We came and toured the building, and then same thing. I came, visited, was presented. So I am the secretary on the board, and yeah. So it's been about 18 months.
Excellent. All right. And again, if you're just joining us, this is Senior Tech Coffee, and we're talking to the board members of Open Arms Assisted Living about their technology implementation. I'm going to fire up the presentation again because I wanted to talk about some of the technological innovations that, hold on, let me make sure I'm sharing the right thing here. Okay, are the slides back up?
Yes.
Great. Okay, I had a couple different windows going with my browser. Wanted to make sure I got the right thing. Okay, so at any rate, you touched on a couple of these things already, Suzan. Telehealth technology. But you've also incorporated the ability to for the residents to initiate an emergency alert for themselves. There's also connected devices, smart appliances, as well as a lot of data collection and reporting. Any of you can jump in at any point here, and let's just break it down, shall we?
Sure. I'll start with how it all got into the building, and then Suzan can run with how it all kind of operates. So what we did, gosh, it's got to be about 3.5 years ago now. The property itself had a lot of asbestos. So we had to go in and mitigate and remediate a good part of, if not most of the building. Well, that allowed us to basically rip out all the interiors down to the framing. And at that point, I was able to bring in a fiber optic infrastructure from the street then into the existing building, and that fiber optic infrastructure would allow us the synchronous capabilities for telehealth and telemedicine. So bringing in the infrastructure from the street, we then started looking at vendors for the actual devices that we would plug in inside. At that time, it was still kind of clunky in terms of the equipment that was available in the telehealth world. So we went through a couple different vendors and looked at a couple different things, and we had a contact at the VA, worked with me and showed me a lot of devices there in their offices and what they use. So I was able to kind of get a hands-on understanding of how the small devices will have to connect to the overall infrastructure of the property. So from there, we started to, understand the cost of those pieces, how they would be connected to other equipment, and then how that connection would transfer data through our infrastructure and then to an end all public health record, emergency record storage, and then the person that would actually operate the software. So all those components started to unfold about 2.5 years ago. And then that's when Suzan and Morgan started to come on board, and we were able to then select that third party that would be organizing the data, handling the software aspect, and then strategize and be able to develop the hardware aspect. And then we took those aspects and integrated them with smart television technology so that all remote patient monitoring would just come right through your smart TV. So you wouldn't have to get out of bed. The devices are all Bluetooth, so they can be easily mobile and move around the room. And then there's one central telehealth room where Suzan is right now that has the capability to be more of a diagnostic area. It can be more private in terms of you and your doctor and your family, and then facilitation. And then it can also serve as a therapy room. So that's how we organize the actual technology components and the different people that were involved with it. And then we were able to create the structure where Suzan can just facilitate it, serve as the interface between the person and the technology. And we would hopefully be able to save on lots of money in saving hospital visits and downtime from families and the complexities of having to get a loved one from their facility to a doctor. The emergency alerts, we have a remote system where if somebody does have to push a button, they're wearing that button and it relays itself back to the caregivers and everybody knows that there's an emergency immediately. The connected devices, our appliance packages, and all the TVs are in addition, that the hot water heater, for example, all these are available on apps, so we can monitor, adjust, or start, change the temperature of the water heater for that matter. We can do that all through a smartphone for appliances and the devices. The collection and reporting, that's all through the telehealth system, which Suzan can talk more about. The idea is that our entire infrastructure in the building is wireless. So we have a wireless mesh system that distributes all of the bandwidth throughout the whole facility. So the churches can use that bandwidth. The residents can use that bandwidth. The staff can use that bandwidth. And we designed in an ice cream pub so that families that are joining the residents from church or what have you, they can use that bandwidth in the ice cream pub, and everybody can be accessing the internet accordingly. All of our lighting systems are LED lighting that are all on remote relays. So the switches are remote switches to the light fixture. They're not necessarily all wired together. So it is one large integrated system. Our motto is, what we want to do is have our technology serve as an interface with the resident, but not be in the face of the resident. So that's where I'll stop, and Suzan and Morgan, you guys can run with it for a bit from there.
Well, and I'd also want to ask, and again, anyone can jump in. You have Bluetooth medical devices as well that can collect data on the residents, and maybe one of you can speak to those things as well. And I'm going to actually jump to the next slide where we talk about, first off, what is telehealth? Basically, the ability for care providers to communicate with your residents over a secure video call, exchanging secure messages with the medical team, and then some of the remote patient monitoring that I was alluding to a moment ago. So please jump right in.
Go ahead, Suzan.
Oh, yeah, so just for clarification, so we have a foundation. There's two terminologies that are being used. Oops. Oh, there you go. There are two terminologies that are used interchangeably, telehealth and telemedicine. But just
Okay.
for clarification, telehealth is sort of the umbrella of everything, and telemedicine fits underneath that. So when somebody is thinking about telemedicine, it is actually the clinician who is having a video conference with the residents. And then telehealth would be remote patient monitoring and all of the other services like you spoke about too, which is the recording, being able to track, monitor, all those things. So with that foundation, we do both. We offer remote patient monitoring. So we have clinicians who come in and they do their first appointments by assessment. So the design is all the providers will come through us, and that we use the facilitation tool for the provider to connect with the resident, right? Or who we call clients. And that's all happening through video conferencing, which is telemedicine, and then also through telehealth, because we are able to create reports on their vitals. And that allows us then to send reports on a regular basis, depending on each provider. So what we do is we bring in the providers. So if a resident doesn't have an existing clinician or primary provider for them, then we have a conversation and say, is that something that you're interested in working with our providers? And if the answer is yes, then we allow our providers, based on their recommendation of care, to come on site for the first 1 or 2 appointments. And the reason for that is to develop the relationship, to determine if the client wants this provider as their primary or if they prefer someone else. So we kind of start that relationship, which we think is really important for that connection with the clinician and the resident. And then based on that, future appointments are done through telemedicine. So then we use the technology that's in place to ensure that they can continue to meet with their physician on a regular basis, not what the normal would be, which is I got to get up, I've got to call transportation, and in every 3 months, I go see my doctor. We work with the clinicians to make it more frequent than that. But as Peter had said earlier, what's really nice about it is each resident has 2 choices. And we ask them, which one do you want? Do you want your appointment through video conferencing in your room, which makes it convenient for the physician? The person gets to see what your room looks like. Or is your room maybe not a place that you want to do it? So then we offer the telemedicine opportunity inside of the telehealth room, which is where I am. I think the other thing too that's really neat about telemedicine and the technology that we're using is that we are piloting, probably I think it's going to be out within the next 15 to 30 days, to invite a family member. So kind of what happens a lot of times is that family members either hear about their care of their family member secondhand, or they aren't able to attend appointments because they can't get out of work. They've got their own family. So what we're going to be offering is the opportunity through the technology to bring in a third person, and that is a family member. And so it's a whole process. I think that's important that we put together. It's just not, let me go grab Zoom and turn on video and here we've got telemedicine. It's a whole structure and it's a whole process that we've put in place to make sure that we create a model that provides the best care possible, and yet utilizing the technology that exists today that maybe some are uncomfortable with. But everybody's told up front, you know, when you come and you have an interest in staying in open arms, our form of care is telehealth and telemedicine. Do you want that type of care? And they've got to be able to say, yes, that's the type of care, I'm okay with it. And then we move forward from there.
Gotcha. Understood. I'm just going to throw up the slides again really quick because I wanted to share some of the benefits of telehealth and telemedicine. So as Suzan has mentioned, residents can attend their appointments from the privacy of their room or from your telehealth room if that's their decision. It reduces your residents' potential exposure to COVID, which is of course a huge deal right now. Saving time and money as far as traveling is concerned. In our preliminary discussion prior to today's discussion, you were mentioning the fact that some residents or elders generally, they can spend hours just waiting for transportation and getting to appointments and that sort of thing. So this is a huge savings of their time, reducing wait times for those appointments. And then they can also be used for, things like physical therapy or exercise, in addition to just meeting with physicians and other healthcare practitioners. Anything you want to add that didn't make it on this list?
Yeah, I think Morgan can touch a lot on this. One thing that we're also focused on is trying to reduce readmission rates to hospitals. So if someone leaves the hospital, comes back to their room at Open Arms, through the telemedicine and remote patient monitoring program, we're really going to do our best to keep that resident from having to go back to the hospital and putting undue burdens on that healthcare system. But Morgan really is, she's the marketing brain of us, and I think you might be able to help out a lot more with this.
Yeah, Patrick, thank you, Peter, for that intro. Patrick really touched on it. I know from my clients, a trip to the doctor could be the full day, and it's not comfortable. It's waiting for accessoride or a bus or family member. It's a lot of coordination to make sure you can get that transportation to the appointment on the day that you need it with the person you need. And sometimes you wait 6 months to get that primary care appointment. And what's happening to you in that 6 months if you're already at a place where you were ready for that appointment? You made that call because something was going on. The remote patient monitoring piece, so tracking heart rate, tracking weight gain, a lot of the chronic diseases that we see that require someone to live in assisted living. If you see a change, if you can catch a change in someone's weight where they have no business putting on weight, but all of a sudden they are, even 2 pounds heavier, that could be water, and that could be a sign of something else more detrimental coming. And with this technology, we can catch that earlier, and we can have the doctor get as many reports as they want to be able to monitor that very closely without this person having to ever go out. So I think that's a huge piece of this. And Suzan, you did a really, really great job of explaining telehealth and telemedicine. That was excellent, by the way. Thank you for that.
Yeah,
Well, and
thanks for clarifying that.
It's one of those little details that you think everybody gets it, but when you do, it's like, oh yeah, okay, I get it now. But Morgan, I want to follow up on what you just said. I think you're absolutely right. It's being that preventative maintenance, that preventative care for somebody's health. And I think there's a comfort for the family members as well as the physicians to know that there is preventative maintenance actively, not reactively, but actively occurring. And being able to work with even private providers where somebody, has their own provider, we work with them to say, look, we're going to do this anyway. We're going to take their vitals on our technology. Do you want, to receive the reports based on this person's healthcare and the care that you want to provide? And I think that's important because it's not just restricted, but it's the full facility, right? And we're going to work with whoever you want. And I think the technology allows us to do that. There's no restrictions around it. And that's one of the beauties of telehealth and telemedicine.
Well, and also, just the fact that you're saying there's the preventative care angle here. That completely flips the healthcare paradigm on its head as far as the way that healthcare works in this country. Healthcare in this country, generally speaking, is reactive, right? You have a problem, you go see somebody to take care of the problem, as opposed to, the upfront care that's necessary to just live a healthy life. And really, we're touching on one of my next questions, and I'll just maybe ask you to add to it, is how are these technological innovations improving the overall quality of care for the residents at Open Arms?
Oh, wow. I think for me, based on the conversations that I've had with our residents, is that they're not waiting 3 months. So we're intentional about working with the staff here. And so I meet with the staff every week, and I get a lowdown of how's it going? Do we need to have anybody come out? How's their appointments? We don't wait 3 months. We actually work with their provider to be more proactive or more intentional about ensuring that their care is happening more on a monthly, if not biweekly, based on their health care. And I think there's a huge difference there. And the reason why I say that is because of the convenience that they don't have to leave the facility. Their doctor can give a 30-minute overview versus, having to wait 2 hours to get in there. So there's a lot of intentionalness on both sides. We're actively working with the executive director and her team to ensure, because that's one of the things that we asked the question in advance was, what type of care are you wanting and expecting from us to ensure that your clients, your residents, receive the best health care? And one of the things that she said was exactly what Morgan had identified too. We see too many times in assisted living facilities because the doctors aren't available, they're overstaffed, nobody can come pick up the person. It's irrelevant as to what the reason is, but they're not consistently monitored on a regular basis from their primary care. So we don't know if they go from being absolutely healthy and then 3 months later, the doctor sees them and they gained 20 pounds, right? We could have caught that earlier had we been able to do that and been more intentional. And so that's kind of like our role, is to be more intentional with the providers to ensure that that person is seen more frequently based on their care plan. And how can we be preventative maintenance? And that's also where the technology comes in, because again, it's an intentional form of care, not a reactive, but a proactive, where we monitor their vitals, right? We monitor their weight. We provide those reports to ensure that, hey, we've got somebody showing that their blood pressure has been off for the last day. Not only is the facility seeing that, but now we are able to report that to provider and see that care goes in. I think on a side note, this is just a little plug, but when we started meeting with the facility executive director and her team, one of the things that we learned was there's the regular care and then there's 911, right? So like Peter had alluded to earlier, we have primary care. The doctor sees their people, they get behavioral therapist appointments, occupational, PT. And then if something happens, they fall and they've got a little bit of a cut, the facilities, most assisted livings aren't designed to take care of that. So it's a 911. What are we doing about care in the middle, right? What are we doing about that emergency triage before we go 911? And I think that's another form of care that can be utilized and implemented. And based on the conversations we're having with some doctors and organizations and even the city, is that you can provide this triage form of care using telehealth and telemedicine. And so for us here at Open Arms, our design is to have a full opportunity of care. So we have the regular doctors using technology. We have the emergency triage doctors using technology so that nobody leaves their room, nobody leaves the facility, and only do that triage if it's designed 911. Do we need to go to 911? And that to me is a full rounded care for this, each one of our residents here at Open Arms.
Yeah, and Susan's done just a fantastic job organizing. I can't tell you the brain damage involved. As an architect and real estate developer, I have to look at the whole building as a functioning operation. And the theory that led the design of this is out of the Eden alternative. So the idea was that we would have 2 households within the same building. So we can track the group of people as they age together. And we're looking at diet, and we're looking at, like Susan said, behavioral and occupational and physical. We're looking at their spiritual care, which is our association with the church. And we're looking at their socialized aspects, which is that ice cream pub. How do we get some intergenerational activities so that we can look at people's overall care, not just from a drug or a pill, but from their daily activities, their daily health in terms of food intake, their comfort with the technology that's available to them, which is where Susan comes in, and then how do they feel overall? Like when they wake up in the morning, are they happy to be alive? Are they happy to be walking around? Are they happy to be playing games? That's Morgan's voice in my ear, always thinking about the person first and not the facility. And that's where our person-centered care design model came into play. So everything from the Bluetooth weight scale in the room to the residential range in the community room where someone can make an apple pie. From technology to pie is how we've thought about bringing in the Eden alternative to this facility.
I want to hear about the app where I can order my ice cream. When are you going to talk about that?
I'm working on that one. I'm working on that.
Gotcha. Okay.
And I want it
Just-
ready to
just-
give to me as I walk in.
Right. And the robot delivers it to my room.
Exactly.
I'm working on that one too, by the way. I'm working on that one too.
Nice. So we touched on it a little briefly a few minutes ago, but regarding COVID-19, first off, I guess two questions. Have there been any COVID cases at Open Arms? And secondly, how has the model, the technology model, or just the model generally of how Open Arms works, how is that working to enhance the safety of the residents vis-a-vis COVID?
At the moment, I don't think we've had, and correct me if I'm wrong, so I don't think we've had any COVID cases.
Nope.
The design of the facility is such that every bed has its own privacy door. So in no cases, unless you want to be with your wife or your sibling or what have you, in no cases are two people in the same bedroom. So we can prevent the transmission of any airborne infectious diseases. Everybody has their own HVAC controls and their own HVAC equipment. So nobody's sharing the same airflow. The only situations that we have to be, careful about are where people use the same bathrooms. There's a public bathroom in the hallway and so on and so forth. So we keep actively sanitizing and disinfecting and doing all the things we have to do from the janitorial aspect. But from the design of the building, like I said, unless you want to be with your spouse or your wife, your spouse or your military buddy or your brother or sister, everybody has their own door.
Well, and on the technology side of it and the healthcare, so when a new resident is accepted after their assessment and they want to move in, they're put into an immediate 14-day quarantine, So that helps. And then we also have it where, because they are independent, they have the ability to go out, rather if it's with a family member, what the case is, but when they come back, they're also required the minimum days to be quarantined, again, not to expose themselves. But with that, kind of think of it this way, we've already got them maybe scheduled for a behavioral therapist appointment. So rather than sending them back out and having them to come back and be quarantined again, what we've chosen to do is use the technology, and now they can have their behavioral therapist appointment through telemedicine, video conferencing, and not miss that. But also they have an opportunity, which I think is critical. I want to talk to my behavioral therapist. You know what? I'm quarantined for another 2 days and I'm watching everybody else have a good time. I'm not doing okay. And so we're able to kind of use that technology. We don't miss an appointment. We don't put unnecessary quarantine on the person so that they can get back into the community. But at the same time, now I get to talk to somebody, right? I'm a resident and I get to talk to somebody about my struggles, and I get to talk to somebody, and I don't miss that appointment, which is critical to my well-being, and just having an opportunity to kind of share with my frustrations and my struggles. And technology's allowed us to do that, which I think is awesome.
Indeed. And do the residents have the ability through the video conferencing to also communicate with their friends, family outside the facility?
Yeah, so I just had a conversation. It's funny you should even bring that up, Patrick. I just had a conversation last week with the CEO of the technology that we use. And that is actually one of the key areas. They've been finalizing up the last bit of bugs. They've kind of been doing some testing, beta testing with inside. And we're anticipating that we will now be able to create each family member or friend, right, a user ID, and that the technology will now allow them to be able to do meets between themselves and somebody else, whoever that other party may be. And I think that's critical as well, right? Is that they have that opportunity, even if they are quarantined or not, or they don't want to get out, or maybe the family's out of state, that the technology in the convenience of their room will allow them to be able to have those conversations. And it's not that, how would I put it? It's not that somebody doesn't have a tablet, right? It's not that we can't use our smartphones. But one of the things I think is critical, on some people don't come with those technologies. So let's just be honest, okay? Not everybody comes with a tablet. Not everybody comes with a great smartphone. But as we get older, we all know that our eyes aren't as best as they should be. And sometimes it's kind of nice that our family members get to see our whole, yeah, I know, mine too, get to see our whole room. So when the technology, and once we're able to, because we'll be a beta testing site for this, once we're able to get out and begin to create these users and create that relationship through their smart TVs, then they get to show them their room. So it's not that I get to show you my little tiny screen, right? But it's that I get to show you my room, and the video allows it to move. So here's my bathroom, right? And I get it. And so it just opens up a sharing opportunity, but also at the same time, I get to see you on a big screen, which helps me personally.
Cool. Yeah, that's, I mean, the communication piece relative to isolation, particularly for our older adult population, is a huge concern, has been for months now. So that's definitely something that's necessary.
Well, and here's, can I put a little plug in?
Please,
I'll talk
yeah.
about store. So I recently read an article, thank you, Mr. Peter, that talked about the struggles that some people are having to get their providers or their staff to accept telehealth and telemedicine. And everybody thinks it's this wonderful, awesome thing, but staff has been designed to do something, and sometimes change is hard. So I think one of the things that's helping us to be successful in it is that our staff is on board, right? And so but again, it's not we're just adding this. This is the form of care. Preventative maintenance, it allows people to have better care. This is the form of care that we are going to provide, and we are providing to each one of our clients. And I think when you have that mentality as a staff, then it allows people to begin to say, oh, this is a complement and a tool that I can use in almost all areas, communication. So the more we get the client comfortable, which going back to your question, Patrick, about communication, having them use their smart TV and having them use the same technology that they use to talk to their family members or their best friend, as well as their doctor or any clinician that they meet with, just allows that comfort, not only with the staff because they see the resident utilizing the tool, but also was the resident themselves that, oh, this is how I talk to my doctor. This is how I talk to my family member. So it's kind of, it's all encompassed, right? It's like, yeah, you could use your tablet, but why not use the TV?
Yeah, and Susan's really kind of touched base on it. When you come from your home to a new location, an assisted living facility, you've been watching TV for 50 years. So you're comfortable with a TV as an interface of communication. Images move back and forth. Voices and songs are heard by you and projected by it. So you are used to watching it and receiving information from it. So our thought was, well, why not use that as your healthcare interface? You're used to the screen. You know how to operate a TV's remote control. It's attached to the wall. So it's really not going anywhere. So how do we use that TV as not just a way to communicate to you, but for you to communicate to it? That's where the interface became, okay, how do we focus on this being an interface, but not like right in your face? And I think this is starting to evolve pretty well.
Mm-hmm. Yeah, I would agree. What we did too intentionally is, excuse me. So every resident, when they come in, they have 3 appointments that they must attend. We usually try to do within this first 7 days, kind of depends on when they come in. But they have a PT on site. So they have a physical therapist who shows up and gives them evaluation, rather if we can bill for them or not. So they will walk away with at least an assessment. They get an occupational therapist coming in, same situation. They will get at least an assessment so the family members and the caregivers know what needs to be worked on. And then they will get a behavioral therapist appointment. The occupational is about day-to-day activities. How can we keep you dealing with your day-to-day? What are some of the areas? And one of the, so that you can be productive and efficient and you can get around and you can be mobile, right? You can live. What are some things when you want to work on? And one of the things that we're very intentional is after they get their first initial training from us, we make sure that the occupational therapist adds video conferencing, telemedicine to their daily care plan as a way to get more comfortable with it. Now, we know that there's going to be somebody like, no way. And that's fine. We have somebody on site, part of the team. But for those, it just becomes something that, again, it's a tool that they can use for their interaction every day, once a week, whatever the case may be. But having it a part of their care plan, I think is just as important, because it breaks down those walls and those barriers, but it builds them up for their independence in a new way.
Excellent points. We touched on this, actually, Suzan, you touched on this sort of peripherally a minute ago. I'm curious to know what some of the challenges are in adopting telemedicine and telehealth technology among providers. And we touched on this in our preliminary conversation about maybe some of the resistance or just unfamiliarity with the technology. Would you mind touching on that just for a moment?
No, not at all. I think you're right. I mean, I always have this saying that I tell everybody: there's no amount of money that we could have spent around the world to market telehealth and telemedicine that the pandemic did in 60 days to expose the acceptance of telehealth and telemedicine, right? I mean, the pandemic, in some ways, that's kind of what they call those little silver linings. There's an advantage to it. But that doesn't mean that everybody got on board and said, absolutely, right? So I think for me personally, what I've heard and what I've seen, the difference between those physicians that are willing to get on board, and it doesn't matter who it is. It could be a laboratory technician, it could be a nurse practitioner, it could be a medical assistant. It's irrelevant the role, right? It's the mentality. I think for me, what I'm seeing in the medical field is that people were trained that I'm supposed to touch you. That's my training, okay? On top of that, you're asking me to change that. Can I really do that? So that's a mentality. But I think what's just as important for me, and based on some of the things that I'm reading, it's a process. If you do not intentionally represent like that, telehealth and telemedicine is a form of care that I want to provide for these situations. So that's a process, that's a work stream. And I think when we take baby steps in that way versus saying, well, I'm going to do it 100%, or I'm going to do it for whatever I need to, well, you're not intentionally grabbing your staff and saying, hey, this is how we're going to provide care for these patients who have these particular issues, and take your baby steps into it, then I think you're going to have resistance. And I think that's in anything. It's not even just in healthcare. That's in any type of situation that you're going to be in. But I think the pandemic, one of the things that it did do is it exposed that this is absolutely possible. It exposed it to the patient and exposed it to the medical field, right? But now it's not just about a Zoom meeting, right? Because that works out great, but now it's about a process. It's about an acceptance tool as a form of care that we want to engage in. And I think that when people begin to seriously look at an implementation, not just a Band-Aid, then we will begin to see more acceptance of the tool. Now, let me be honest, this is my opinion. Telehealth and telemedicine today isn't for everything. It's not going to fix everything. However, there are doctors who are doing surgery through telemedicine, right? So there is an exposure to it. But to get your staff and to get the physicians on board, I think it has to be an intentional step toward recognizing it as a form of care, and then beginning to challenge your staff as to how they can begin to make changes and accept it as a form of care. And then how do we put a process within our offices, assisted living facility, hospital, it doesn't matter. How do we begin to implement it and create an actual process around it so that it becomes part of who we are?
Yeah, and I think another layer that I've experienced from the provider side is there's going to be 50 different apps and 100 different software platforms, 13 different kinds of hardware before some platform starts to standardize all of it. And we're not there yet. And I think the providers want to see some standardization of software platforms before the hardware platforms, but on the software platforms. So for example, Epic is a strong one in healthcare. That's just one of the myriad types we have available for telehealth right now. You know, the VA has their own platform, and each different hardware provider might have theirs. So that's got to evolve a little bit. And then I think you'll see a lot more providers jump on board. In the meantime, there are going to be those mavericks that say, yeah, let's get on this thing now. And we're talking to some of them, I believe. And I'm excited to see where all that goes. You know, I'm excited to see where that goes.
I agree. I mean, on a side note, I'll give you an example. We interviewed a doctor of nurse practitioning, and this particular person was absolutely on board, very excited about it, started to come up with thoughts, give me my user IDs, show me how to do it, boom, I'm ready to go. I'm talking to another doctor, an actual physician, and he's got all these questions. He got more questions than I have answers to. And immediately I step back and I go, why do I have one that's okay with it and one that's not? Right? So the one that's okay with it is going to be a lot easier to work with because they're already thinking ahead, how can I utilize this tool? Where the other one is still thinking behind, why do I need to get there? And so that in itself also reveals where people are. But I think either way, there's so, like Peter said, there has to be an evolving of the technology. But if you're the mindset that this is something I want to get around, this is something that I really see as our future, there's tools out there you can use today. And you can get reimbursed. I think that's key too for the providers. You can get reimbursed. You can make money off of this. And that's key.
Yeah, indeed. Well, and it also sounds like there, not only does there need to be some standardization in terms of the products that are being utilized, but maybe also in terms of the process of using them.
Mm-hmm.
So.
Yeah, Patrick, I think you're right. And I think we're, by the end of this pandemic, I think we'll have hopefully some of those questions answered.
Right, indeed. And it sounds like the pandemic was a real accelerator in terms of how adopting the technology, at least in some quarters.
I would agree.
For sure. From a cost perspective, you know, if I have an assisted living community and I'm watching this talk and I'm interested in maybe implementing this type of technology, what kind of costs am I going to be facing?
That's a hard, I can't answer that question because the infrastructure determines everything attached to it.
Yep.
So if you don't know what the infrastructure is, or you don't know if you have it, then you don't know what your costs are going to be. You really got to look at it from the street to the TV.
And then I would say, to follow up on that, for the assisted living facilities, based on what I've learned in the last 6 months, a lot of assisted living facilities aren't able to be financially reimbursed for the care that's done through telehealth and telemedicine in some little forms. So outsourcing it to, like when Peter outsourced it to us, then it allows us to come in and bring a care, and then I'm a clinic. I'm not an assisted living, I'm a clinic. So by being a clinic on site, now we can bring telehealth and telemedicine as a form of care, and then that's the benefit that the assisted living facility gets with whatever, as Peter said, platform they've chosen to use.
Gotcha, understood. What technologically and otherwise, what's on the horizon for Open Arms Assisted Living? What's in your plans for
Tell us, Peter.
2021 and beyond?
So what swims in my head is can be interesting from time to time. I was I had the opportunity to participate in Aging 2.0 conference a few years back, where I witnessed a robot that would accept lots of prescriptions and then package them per your prescription requirements into daily packages. So what's swimming through my head is, what's the next aspect of technology that I can include either attached to the facility, working on the facility, or working for the residents. And if that's the next best Roomba that could, vacuum the floors, or the robot that can dispense medications. Those are the things that now I'm thinking through that are remote. They can use the bandwidth we have. They're not necessarily attached physically to the facility, so they can be mobile. And how does that integrate with the people? So that's kind of where my head is swimming next, is reasonable robotics, functional components, and of course, everything's got to be person-centered.
For sure. All right. Well, I would like to, let me just take a quick glance here. I would like to open it up for questions from the audience. Does anyone from the audience have any questions? And you can just unmute yourself, or you can type it in the chat. Either way, I'd like to open it up for questions. All right.
Well, I don't necessarily have a question. I just want to say kudos to all of you. I'm coming from it and Morgan, I know Morgan very well, coming from it from two different perspectives. I've been in the senior industry and technology for most of my career pretty much now, but I'm also coming from it as a long distance caregiver of my mom who resides in an assisted living. And when you mentioned the piece about being able to be in on a doctor's visit, oh my gosh, like that would be amazing, because, especially right now when, I can't, and my sister who's located near my mom can't go into the facility or into the community. Yep. And I just think that's such a critical piece, to keep the family involved. And then just everything that you're doing. I mean, it's just, I'm just in awe, and congratulations, because it's definitely the future of, senior communities. So I love it.
Thank you.
Thanks, Suzanne. That's huge coming from you.
Great. Thank you for the feedback on that. Any final thoughts from any of our panelists?
I have one thing I like to add. We were talking about person-centered care, and Suzan, you mentioned briefly increasing independence. And I feel like in my career, there's a feeling of a lack of control in almost every aspect of assisted living. And when our health starts to become questionable, maybe in some areas. And I really feel like the model, it's hard to go first for anything, but the model at Open Arms is one that we are built to give independence back to people. So we're hopefully having someone move in who needs the care, who now has someone paying attention to every aspect of their care, as Peter and Suzan both alluded to, but also to increase their self-advocacy. Here's how you check your blood pressure every day. Here's what it means when your blood pressure goes up and it's a spike. And here's how you can be in control of that. Here's how you can decide what you want your day to look like and who you want involved in your life, and just increase that opportunity for independence, which is something that a lot of people don't think of. If you're leaving your home to go to an assisted living, oh, you're giving all your independence up. But it's not true. It's the opposite. Yeah. You're increasing your social capital. You're increasing your access to services, transportation, opportunity, engagement, technology. I mean, you are getting so much back if you realize what you're committing to.
I would agree with that, Morgan. And
having the church active right there on the property. We have 4 congregations that are there all Sunday long, a couple of times during the week. So there's always activity and something to watch.
Mm-hmm. Well, and think about what we didn't even talk about, right? The garden that we have in the back, right? So now we have an opportunity for individuals. And I mention it just because I was talking to the occupational therapist about one of the clients, and she says, I'll be so ecstatic when we have weather and we can begin to utilize the garden, because I can then move this occupational therapy into the garden and make it fun, but at the same time, work on remote, how do you dig and how do you take responsibility for something? So I just think that whole package of what Peter and the St. Andrews did at the very beginning was to encompass the care, but it's not just inside of a facility, it's outside. How do I raise my own garden, right? How do I raise our own vegetables? And that taps into independence, because I can now pull that basil out. I can now pull that carrot or whatever it is out, or I've got to go trim it. And so it just, not only your mental, your physical and your body, but there's the spiritual side. And then why not get your independence back, right? I mean, it just allows you to have honor and respect as you're aging, which is really what we all want.
Can you just make the robot do the weeding though?
I'll do the weeding.
I'll do it.
I like weeding.
It's stress,
Morgan.
I'll come do some weeding.
Come on over, Ruthann. You're right down the street.
I know, I'm just down the street, so.
We'll tap into you, okay? You'll need it.
Yeah.
All right. Well, listen, thank you so much for joining us today. It was really a pleasure to have you on the program. And I know that this is a really important initiative, I think, going forward for assisted living, but just generally speaking for senior care. Anyhow, I really appreciate you being on the program today. Thank you so much.
Well, thanks, Patrick.
We're going to just wrap it up here. I just wanted to share the schedule for the next episode of Senior Tech Coffee. We're going to be talking about how do you understand your digital footprint? What is your digital footprint? Your digital footprint is essentially the record of your activity online, whether it's active or passive. And we'll talk about some ways that you can take control of that for yourself.
Ooh, love it.
Here's some contact information for the folks at Open Arms Assisted Living, the facility itself. You can see more pictures of the facility and some of the things that they've done there. And also for myself, if you want to get a hold of me, best way is just to go to primeoflifetech.com. You can schedule an appointment. You can learn more about Senior Tech Coffee. You can also follow Prime of Life Tech on Facebook, LinkedIn, or you can also see recordings of these programs on our YouTube channel. Anyhow, thank you once again for joining us today, everyone, and particularly our guests. And we'll see you next time. And thanks once again. Have a great day, folks.
Thanks, everyone.
Thank
Bye-bye.
you, Patrick. Thanks, everyone. Great
Thank you.
to see you, Dan.
Senior Tech Coffee.